Thank you all for coming on a very rainy and unfortunately cold day, but hopefully spring is returning again soon. So I had spoken with Dr. Young, and I knew that he was going to be talking more about treatment and medication. And so my favorite thing to talk about is how to improve gait and balance and some of the issues people deal with Parkinson's. And I'll touch a little bit on medication, but it's more to do with the non-medication treatments. So I wanted to talk about gait and balance and how they interact, talk about some of the challenges of gait and balance in people living with Parkinson's, talk about risk factors for falls, and talk about strategies we can use to improve gait and to improve balance. So how do gait and balance interact? And gait is our term that we use for walking, balance, obviously, avoidance of falling. There are three main functions of gait. The first one is navigating around obstacles. The second is moving forward, obviously. And the third one is maintaining your balance upright while moving forward and while moving from side to side as you walk. So navigation forward, people use stepping patterns to avoid obstacles and to steer as they move. And in people who have a skilled gait, most of the attention is actually focused on navigating. So you're looking at what you're stepping over and around. And the gait is much safer and it's a predictable gait. In challenge gait, so in Parkinson's or in difficult walking situations, your focus goes on your balance, or your focus should go on your balance, and we'll talk a bit more about that later. And so it's more of a reactive. You're reacting to balance changes rather than always maybe focusing on what the obstacles are or how you're trying to move forward. That's actually me. I'm a terrible hiker, and I'm walking down a mountain. You see everyone else is standing up straight, and I'm kind of crouched as I'm coming down. My balance is not good. So the second function gait is moving forward, and there's two main things that become important in that. The first is ankle power pushing off as you take a step forward, and the second is lifting your foot off the ground. And the foot clearance even in people who don't have Parkinson's in healthy adult gait is about 0.5 centimeter. So there's not a lot of room to work with, and so you can imagine that if your foot clearance isn't coming up higher, you are at risk of falls. So I just wanted to talk about muscle power in Parkinson's. The ankle power is usually reduced, and so you lack that push off as you step forward. If you can see from this woman here, as she's pushing forward. Does the arrow come up? Okay. As she's pushing forward, she's having to contract her calf muscles. In Parkinson's, that is impaired. As well, there's less hip power also to push you forward. And I'll just show you somebody walking. It's a bit more of a flat-footed gait, and there's not as much push forward. The second issue is the toe clearance. And so for the toe clearance in Parkinson's, often it's more of a flat-footed gait, and so people lack that heel-toe type of pattern. And recall that you've only got 0.5 centimeter of clearance to work with. And the second thing is there tends to be a reduced knee flexion for the swing of the leg forward. And you can see as he's walking that there isn't much bending at the knee, so the foot's quite flat-footed and not getting that movement forward. And then the third function of gait is balance. And, as you know, when people start to walk, they're often kind of staggering, moving. You have to learn how to balance shifting your weight from side to side, as well as keeping your upright posture. And the upright posture is to do with the hip and knee alignment. And you can see here her mom's actually holding up her pelvis, so her hips and knees are up. In Parkinson's, posture often is a problem. People have a stooped posture, so the center of gravity is forward and it changes your balance. There is less movement at the hip and knee, and less hip power, keeping you moving forward while staying upright. And I'm just going to move that forward. As Parkinson's worsens in some cases, and I think one of the things to remember about Parkinson's, when I give these talks, I always feel like I have to do a bit of a disclaimer, but Parkinson's is a different entity in everyone who has it. And so some people have lots of gait and balance problems, some people only have minimal, and so not everything I say applies to everyone. And so as you're listening, I always worry people who are thinking, well, I'm going to have to deal with that. And you may not, but I think, knowledge is power, and to be aware of things to watch for. One of the things we find in more advanced Parkinson's is the step-to-step variability is irregular. So when people step, there's usually a real rhythm to their step in how far they step and how evenly. Parkinson's affects that, and so there's an irregular step pattern, and we know that's a predictor of falls, so we're always concerned about that. People also can get into very quick, rapid walking pattern with small steps. It's called a fascinating gait. Most people have heard of the freezing of gait, that in some people you walk and you stop and you can't keep going. Obviously, the involuntary wiggling movement can affect balance more. And then balance reactions, your response to balance isn't quite as good. So the next thing that becomes important in Parkinson's is paying attention to gait. So we know that even in healthy elderly people, they did a study and they found that when people stop talking while walking, that predicts a balance risk. People are learning to focus on their gait, on their balance, rather than focusing on walking. And 80% of people who did this stop walking while talking actually had a fall following that. It becomes a bit more complicated in Parkinson's, certainly as gait becomes more challenging, then the attention has to go on to balance and maintaining a gait pattern. And to manage these secondary tasks, talking on the phone, talking to somebody you're walking with, carrying things in your arms, all of that can impair balance. So in a dual tasking situation, it does not only impair balance, it also impairs your step variability. And we did a study looking at dual tasking in people that had Parkinson's and in people who didn't have Parkinson's. And in the people who didn't have Parkinson's, they chose the secondary tasks were things like counting or doing math out loud, or math in your head, or carrying something in your hand. When we did the math out loud tasks, the people who didn't have Parkinson's tended to not worry about how they did on the math task and were concentrating on their gait, and their gait didn't really change. In people that had Parkinson's, they tended to focus more on the math task at the expense of their balance, and so their gait definitely changed and they were less stable than they had been. So it's the idea of posture second rather than posture first. So not always concentrating on that. And as well, we know with Parkinson's that if there is any memory impairment, even the idea of executive functioning or trying to do two things at the same time, that does increase your risk of falls, especially if you are trying to do two things at the same time. And just a few words to kind of highlight falls risks, and I'm probably, as people say, preaching to the choir. You guys certainly know that's a big concern. And we know from the literature that Parkinson's is one of the highest risks for falls overall. Gait problems increases that, and fear of falling increases that. And about half of people with Parkinson's will have a fall at least once a year. And it's 3 times the overall risk. So there are risk factors for falls that we see on a consistent basis. Fear of falling is actually one of the highest risk factors for falls. So, as you know, if you're out walking on ice, you're always very careful about moving, trying to not move your feet, and it's often then that you'll have a fall because you've changed your walking pattern. So being afraid of falling actually can lead to falls. This idea of the regular steps, inattention, reduced physical activity, freezing of gait, cognitive impairment, having more advanced Parkinson's and older age. Many of these risk factors can be changed, though. So that's where it's important to be aware of them and think, what can I do to change it? So certainly fear of falling can be modified, and I'll talk about how that can happen. Having regular steps can be modified. Learning about attention to gait, how to avoid dual tasking situations, strategies to deal with freezing of gait. Although we can't always reverse cognitive impairment, there are medications that can help, and it's important to identify it. And then also keeping your Parkinson's medication optimized. So there are, when we look at the Parkinson's medication, it's always important to know what it helps and what it can't help. And so the Parkinson's medication can help improve your speed, your stride length, and it can help somewhat with that irregular gait pattern, trying to make it more symmetry. And the medication helps with the scale of movement. In the gait features which don't improve with medication are the muscle contraction patterns, balance. Freezing of gait often doesn't improve with medication, and as I talked about, this step-to-step variability, partially responsive and partially unresponsive. And so these are the things that we start to think about other treatment strategies. So that was the bad news, hopefully. Hopefully we're moving on to the good news. There's more and more research being done about ideal treatment strategies for gait and balance. And as we said, certainly optimizing your medication is important, but there are many other factors that come into play. And from research, we know there are 4 main things that can be brought out to help with balance. The first one is exercise or capacity training. The second is cueing strategies. The third is cognitive movement strategies. And the fourth is balance exercises. So a pattern of working on balance training. So I just wanted to talk about exercise and Parkinson's disease first. What we know about exercise from animal research is that exercise from animal research actually slows the loss of brain cells. It keeps the brain cells living longer. We aren't able to really study that well in people because in the animals they can have them exercise and then do autopsies and look at the changes. None of you want to do that, and I understand. Don't let anyone talk you into that. So we can't prove it in the same way physiologically, but we know that from animal research. We do know that in people, although in Parkinson's you lose dopamine-producing cells, you don't lose all of them, and so the exercise helps stimulate what dopamine you have in your brain to work. And so often people will say, if I exercise, I'm much better to move all through the day. And then a third finding, which has only come out in the past few months, is in animal studies of animal models of Parkinson's, the exercise actually increased the chemicals that have to do with how the cells talk to each other. So we know that in the brain, nerve cells talk to each other across these things we call a synapse. And in synapse is where two nerves meet and chemicals are transmitted across the synapse. The exercise in Parkinson's actually improved how those crosstalk, how those synapse points between brain cells work. So it improves the crosstalk, and that's how the brain functions better. So if you have more crosstalk, then the circuits are firing faster and they're working better overall. We do know about the immediate benefits of Parkinson's, and of exercise in Parkinson's, and the most common motor benefits are things like improved balance, improved gait speed, improved functioning, your activities of daily living get better, your strength is better, and when we do things like rating scales, we do see improvement overall. There's also, as Dr. Young kind of talked about the non-motor symptoms of Parkinson's, we know that the exercise also helps your quality of life, your mood, your sleep. It can help with the low blood pressure, so he talked a fair bit about low blood pressure as well as things like salt, wearing support stockings, keeping the head of bed up. Exercise can help with that blood pressure drop. It helps your overall cardiovascular fitness, and there's research both from Parkinson's and from Alzheimer's studies, although Parkinson's and Alzheimer's are very different problems, but in both of them, memory and executive functioning improves with exercise. So it actually helps the cognitive pathways, and probably with the idea is it improves that crosstalk across brain cells, so the brain cells are working faster and more efficiently. In terms of what to do, there's actually no one type of exercise that has outweighed others. There are ones that are better for particular problems, but no one's found the one thing that we say everyone has to do this. How much to do, how intense and how much. Moderate intensity is probably as good as high intensity. So there has been a study looking at low intensity, medium intensity, high intensity, and found that probably moderate is as good as high intensity. People are still looking at that though, and so there are some schools of thought that a high intensity exercise, really getting your heart rate up very high, may be helpful. There are concerns within Parkinson's that a high intensity may be too much and you're putting yourself at risk of injury. And so the general recommendation is a moderate exercise. How long, from all kinds of years of exercise research, people would say at least 30 minutes 3 times a week. And I know in talking to everyone I follow, they're way over that. People are exercising every day and quite involved. If you're having a particular issue, if you're having balance problems, if you're having more falls all of a sudden, if there seems to be a particular issue, physiotherapy programs are likely the best to give you guidance as to what to do. So, often people are having posture problems, and physios are good at giving you exercise and tips to work on that can help deal with problems like posture, or if there's a particular thing that you're struggling with, like I can't get up out of my chair. There's many ways of approaching that. One of them is to work on exercises to get up out of the chair. The other is to raise the chair. And sometimes it's a bit of each, but certainly involving physio and probably occupational therapy too. You want an exercise that you like. If you don't like it, then you're not going to keep doing it. And so that's a big thing to think about, right? If it's fun, you'll do it. If it's not fun, then it's going to go by the wayside. And it can be at home, in a physio clinic, in a class. It's partly what you like and what seems to meet your needs. For some people, it's hard to travel to class. And so in terms of types of exercise, I've got boxing there because it's the hot new thing. And I'll talk to you a bit about the boxing research. But there's been many studies looking at physiotherapy intervention. All of them have shown improvements. And there's what we call higher quality studies, so higher controlled studies, that they're randomizing patients to one treatment or the other and evaluating them. And as they are doing more of that, they're seeing bigger benefits, and they're better able to source out what the benefits are. Treadmill walking also has had a number of studies done that have reported good improvements. In gait, it seems to help with that symmetry of gait, because on a treadmill you have to step on a regular pattern, and it does help with that. So a lot of people have found that effective, but the research also would back that it does improve your symmetry of gait and balance. And certainly a community-based exercise program also have been found to be effective. Water training can sometimes be helpful for people who are having a lot of balance issues because you're feeling safer in the water, you're freer to move. Nordic walking training, there have been a number of studies to do with that, and I know a few of the support groups have done Nordic walking programs, and it's been helpful in things like gait speed, fear of falling, because you have the poles to help support you. You are actually improving your balance, even though you aren't always aware of that, but it just gives you that extra confidence, and also builds your cardiovascular endurance too. The We Balance and We Fit, we did a study with that and found that it did improve balance and gait. It was also, people liked it. At the end of our, we had done, you do studies and you have to buy equipment to do the study, and so we suddenly had 10 Wiis at the end of the study. And so quite a few people said, well, I would use it. And so we said, okay, fine, you just take it, and if we're doing the study again, we'll bring it back. Well, I just got one back now, and I think we did the study maybe 7 years ago. And so the person had continued to use it for 7 years and said they liked it, it was fun, they could do it in their home. And then dancing, as you know, has been very popular, and there's been a number of studies looking in particular at tango dancing, probably because it's a bit smoother. I don't know, I've never tango danced. Anyone here who's tango danced? Oh, there's one hand back there. Oh, two. Oh, good for you. Oh, you too? Okay, good. Yeah, that's right. Come on up and we'll see how that goes. Then we've, kind of talked about land or water-based. Music-based is a new area. One of my graduate students is just starting a study looking at music therapy, but it's an integrated music therapy that you're a part of the music program, and so doing drumming while he's playing other music. And they found it helps build in the rhythm of things. And although you're using your hands or you're stomping with your feet, when you do get up to walk, they have demonstrated improvement of things like gait and balance, because it does build in that symmetry of walking. So we'll see how it goes. It's a new study starting, but there have been other studies in the past. And then weight training helps with the strength. It's probably not going to help with your balance, but it's still important to keep your strength up. So because everyone's asking me about boxing, I wanted to just talk about, I think that's actually the photo from in the States. There's the boxing program, and I think it was the one that was on CBC or CTV News. So there has been one randomized trial. So do you guys know what randomized trials are? Do you understand that? Yes? No? No, okay. So in research, there's a whole bunch of ways you can do a study. So I can take all of you and say, okay, let's go boxing, and at the end of it, you can say to me, boy, that was really fun, I feel better. And then my colleague says, well, that's not a very good study, because everybody did boxing and sure they liked it, but maybe it was good because they met new people, the food was good, the environment was good. How can we be better about doing that? So then I can say, okay, well, I'll take two groups, and half of you are going to box. I'll take all the people who want to box will box, and all the people who don't want to box are going to do Nordic walking. And then we'll compare the two groups. And then, lo and behold, boxing looks better than Nordic walking, except then my colleague says, yeah, but the people who chose boxing all were much more physically fit. They worked harder at the exercises. They didn't have as many balance problems. They chose that. People who had more balance problems chose Nordic walking because they were concerned about balance. So how can we say that's actually equal? So that's kind of second level of study. And then a better study is I take all of you and I give you all an envelope that you can see in, and group one's going to do boxing and group two's going to do Nordic walking. So the envelope either says 1 or 2. So that's what we call a randomized trial, that I've randomized you into one group or the other. I don't know which group people will go into. And it's supposed to be better because we know overall that if we randomize people, that we're likely going to have fairly equal groups of people, right? So we'll have some people who are good at things, some people who aren't, some people who like exercise, some people who don't. Then we do the study, I do the boxing, I do Nordic walking, and at the end of it I say, oh, clearly the boxing group did better than the Nordic walking group. And so when we do studies like that, we have more confidence that what we find is true, and it's not just an artifact of who chooses to do what. So does that make sense? Yeah? Okay. So they actually did a randomized boxing trial. They took 31 people, half of them did boxing and half of them did an exercise program. In the boxing training, they did some weight training. They actually did boxing, obviously, and they did some aerobic training. In the other exercise group, they did stretching, weight training, and then also did some balance exercise. And then they looked at outcome. So in the regular exercise group, they actually felt that their balance confidence was better than the boxing group. In the boxing group, their walking speed and endurance improved, and when they looked at both groups, everybody had an improvement in balance, in mobility, and quality of life. So, you know, people say, well, is that good or bad? Well, it's kind of confirming what we know. We know that boxing is helpful. We also know that other exercise groups are helpful. So it's confirming the fact that you don't have to all go out and get boxing gloves. There are many different things you can do, and they're all going to get you to the same point. If you like boxing, that's great. I think it's a great thing to do, but it's not the only thing to do. So I think it's always important, if you're looking at studies, to see how well controlled was the study done, right? Did they arbitrarily take two people? Were they careful about? So the words that you want to look for are randomized. So if they're randomized, then they take a group of people and it's random who's in what group or the other. Cueing strategies. So there's a number cueing strategies, and there's a number of ways of doing that. I'll just go to here and come back to that one. Cueing strategies can be motor, visual, auditory, or tactile. And motor strategies are things like telling people to take longer steps, marching on the spot, thinking about doing a heel-toe pattern. Visual, which is what this lady's doing here, is the idea of stepping to lines or laser canes. And I think everyone's kind of heard about laser walkers and laser canes. They project a line. Are you waving at me or just saying yes? Okay. Laser. You always have a story. I don't think these people are here, so if they do, I apologize in advance. But early on, you have great ideas when you start out. And so someone was having lots of walking problems, and I said, why don't you try putting tape on the floor? So they did. It wrecked their floor. It worked for a while, but it didn't work long term. I think everyone's kind of felt that way. So the idea of the laser cane is it's a laser light coming out of the bottom of the cane. You put the cane down and the light shines and you step to it or you step over it, and then you don't wreck your floors. So don't put tape on your floors. Other people have found stepping over a cane, and so you turn the cane upside down, and as you're freezing, you actually take a step over the top of the cane, or kicking the bottom of the cane to go. So different visual cues. Auditory cues are rhythmic sound, walking to a marching beat. There are more complicated things. There's a recent study done in the past couple of months that they had an instrument in your foot that would record your step, and it sent a clicking sound to your ear, and that kept you listening to the rhythm of your walking. And they, from their study, and it was relatively well done, one of these randomized trials, they actually found it seemed to last longer than just listening to a beat in your ear with walking. We still haven't found the ideal auditory cue, though. And then tactile cues are things like an insole that as you step on it, it'll vibrate, and it just gives you a trigger to have rhythmic walking. People also have had this idea of a moving handrail. It's you actually hold it in it, and it kind of vibrates or moves, and it gives you a trigger to walk. What a colleague of mine and I have done a meta-analysis on some of these trials, and so meta-analysis is where you take all of the studies done on a topic, screen them for studies that are well done and poorly done, and take the well done studies and then accumulate all of them. So one of the problems with all of these studies is they have 20 people in them, or 30 people in them, or 10 people in them. And so you say, well, how can I conclude a lot with only that number of people? So by doing a meta-analysis, you then end up having like 30 people all in a group, and so you can certainly have like 300 people all in a group. So we have a bigger group of people to draw ideas from. From the meta-analysis, visual cues, kicking a cane, stepping over a cane, stepping over light, seemed to help better if the problem was more freezing of gait. So if people were having, does everybody know what freezing of gait is? Is there anyone that wants me to explain it? No one. Oh, no? Okay. So with freezing of gait, where you start to walk and you're stuck and you can't get started again, visual cues seem to work better for that, from taking all of these studies and putting them all together. And auditory cues seem to work better to improve gait when you don't have freezing of gait. So if you're just trying to improve your gait overall, have your steps be more regular, some kind of auditory cue seem to work better. The idea about why cues work is we don't know, but there's a few theories about it. The basal ganglia has to do with controlling scaling of movement. So when, for many of you that have Parkinson's and spouses of people that have Parkinson's, the big complaint I always get is about voice, that the voice is too quiet. And often the person who has Parkinson's says, I don't think my voice is too quiet. They aren't lying about that. The perception of scaling of how loud sound is, or how large you step, or how far you move your arm actually is impaired in Parkinson's. So the feedback to the brain about how I sound, how loud I sound, is actually not what other people perceive. So it's a problem, because how do you get people then to accommodate? And so cueing helps with that, because if you have a line on the floor, then you see, oh, I have to step that far. Or if you hear a beat, then you think, oh, I have to step that fast. And so that gives you a cue. How cueing works is we think it actually bypasses the basal ganglia, which is the part of the brain that's involved in Parkinson's, and it uses other parts of the brain, and we think of it as probably most often using cortical or conscious part of the brain. That consciously I think, oh, I have to step longer, so I'm not relying on my basal ganglia to tell me how far I have to step. I have an outside cue, and I'm using my conscious brain to move, because you don't consciously think about things like walking. They're very automatic. Does that make sense? Some people are nodding. Does anyone have a question about that? It's kind of a confusing concept, and also because we don't actually know that. So we talked about, oh, yes. Yep. Mm-hmm. 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 Yeah, yeah. So I'm actually getting to that next, but I'll just give you the little what's the word, segue. Thank you for the segue. Is I think you've probably heard about the Lee Silverman voice therapy. So it works on that scaling. So I'll talk about that. It's hard because you can't say to somebody, speak up. They say, I am speaking up. Well, no, speak up. I am speaking up. As opposed to with gait, you can say, well, here's the line. This is how long your step needs to be. It's a little bit harder to give them online feedback. So cueing helps with, we talked about speed, stride length. It gives you a better step-to-step variability, particular with the auditory cueing. Helps with freezing, particularly the visual cueing. So different types of cues seem to be better for different problems. The symmetry of gait seems to improve more with the auditory cueing. So what's happened with all of this is the auditory visual cueing works for some people some of the time. The problem is it may not be as long lasting. And so there's more of a move now, and there was an article published just in the past couple of months by a group in Portland, Oregon, who's very involved in Parkinson's and rehab and are kind of on the forefront of that work, and said we really need to include cognitive strategies in cueing, that it can't be just there's a line on the floor. There has to be a thought process, understanding why you're doing what you're doing. And so cognitive strategies are to think about things like standing up straight, think about taking long steps, using a feedback system to help you understand that. And so that's where things like the Lee Silverman voice therapy comes in. Have you guys heard of Lee Silverman voice? So it's a voice program that teaches you to speak loudly without straining your voice. And the principle of it is if you enunciate more. So if I enunciate more, I get louder without having to yell. So in Parkinson's, just like the steps aren't as big, the mouth movements aren't as big, and so everything's quieter. So it's a feedback, feed-forward type of system. And then to be aware of paying attention to your gait, knowing that if you have Parkinson's, you may concentrate more on carrying something than your balance, or on someone talking to you than your balance, or on the grocery list in your head than your balance, to kind of think, right now I'm walking, I need to concentrate on my balance. Please don't speak to me till we reach our end point. So, sometimes and I think I was saying to the physio group, I was a physio in a past life, and I remember walking people down the hall and babbling away to them, and I'm thinking I'm doing the worst possible thing, right? They're supposed to be concentrating on their walking. So it's important as a spouse, friend, caregiver to know that if somebody's struggling with walking, the time to talk is when they get to where they're going and they're sitting down, not as they're walking. And particularly if it's a high stress thing, crossing the street, things like that. And so we did a study, and this gentleman kindly agreed to let me show you the video, but some of you guys have probably seen that. So it's him, this is his usual walking. He has a decreased stride length, decreased arm swing on the right side, fairly stooped, and now I'm asking him to turn And freezing of gait is a terrible, terrible problem for him. And we actually had him have to turn and come back around the gate, and he couldn't. So now all I've told him to do is take big steps. So he's thinking about taking big steps, comes to the end, he still has a moment that he freezes, and then I say, okay, take the big step, and off he goes again, so comes right out of the freezing. What we did with the study, because I tell people who I see know that I tell them this all the time, is we videotaped him doing his normal walking and then walking with the cognitive cue of trying to take bigger steps. And he took it home, and for 10 minutes every other day for 2 weeks, he practiced that. He looked at the video of the two walking, the kind of good and bad, went out for 10 minutes and practiced it. And when he came back in 2 weeks, he was doing better. He was able to better use the long steps. So big deal, 2 weeks. Then we saw him 2 months later, and he was still doing it. And we're like, wow, this is great. He's still doing this 2 months later. 5 years later, he was still using it. Like he was able to retain it, I think, because he'd seen it, he'd practiced it, the image was in his head about what to do, and it was a very small study of people we looked at, and we keep talking about doing a bigger study, but I keep telling people about it, so maybe I won't ever be able to do the study. But having the visual feedback helped, and how we came to it is the graduate student we were working with was a professional rower, and she talked about in rowing, they videotape you, and they say, here's what you're doing well, here's what you're doing wrong, and she said it helps because you can picture it in your head, and it gives you the visual image as well as you actually doing the motor task, and it seems to work, and at some point in time I'll do the study, and then we'll have more to say about that. So cognitive strategies have to be taught to you by somebody, and often physio or occupational therapists can help you to start with that. What's the problem? How can we help you deal with that? It requires some conscious practice, some kind of feedback, and often visual is good. With the Lee Silverman, it's an auditory feedback. People have used things like smartphones to cue them, remember, take bigger steps, and to be conscious of avoiding dual tasks. And we find with the cognitive strategies, as with the cueing, it has similar effects, but the outcomes seem to be a bit longer lasting. Just a few words about balance training. Balance training, again, probably, I am not paid by the physios to do this, but it is important. Balance training, you kind of need someone to start you on what are the right balance exercises you need. Being taught things like core training, trunk strengthening, trunk alignment, posture. There have been studies with the Wii Balance board as well, because it gives you feedback as to how your feet move. And then things like Tai Chi, there's been a number of good studies done. Tai Chi is very effective in improving balance. I made my mom go to Tai Chi, and she complained. She said, it's too complicated. I can't keep it all straight. I said, this is good, Mom. It's going to help your memory and your balance both. So that's kind of two good things. And it is, there have been a lot of improvements with that. And, we talked about at the end of the balance studies, they have found improved gait speed, reduced fear of falling, which is a big thing, right? So we talked about it's not just falls and having balance, but if you're afraid of falling, which is very common, even if people aren't having falls, and it really does help improve that. Just a couple of words about preventing falls. So falls can be due to a whole bunch of things. It can be due to your Parkinson's, other medications, vision problems, environmental hazards, and inattention or dual tasking. So this is kind of an outline of a falls journal, and I keep meaning to change it. But when I see someone and they tell me they have a fall, what I do is I try and do like a CSI of the fall. How did it happen? What were you doing at the time? Was it morning, evening? Were you in an off state or an on state? Were you wearing clothes you may trip over? Was your footwear okay? Were you on the carpet or hard floor? Did you feel lightheaded? Did you pass out? Did you trip on something? And, two reasons. One, to figure out why the fall happened, and then the second is to see, is there anything I can find then to help prevent you having a fall again? Oh, so the falls always happen in the bathroom when I'm getting up off the toilet. Maybe you need grab bars in the toilet. Maybe you need a raised toilet seat. So there are many different things, and it's helpful if you're having falls at the time. Sit down with anyone who is there, jot down what actually happened, because it's going to help you prevent the next fall, which is very important. And, falls often happen if you're if you're pulling out a door and you're stepping backwards. That's the worst time. Carrying objects, stepping away from counters, backing up into a chair. So it's important to be aware. In particular, kitchens and bathrooms are the worst spot for people to have falls, the most common time. And it's often that you're at a counter and you back away from the counter, and backing up, as everybody knows, is often a really difficult thing. So it's better to hold the counter, turn yourself around, and then take off from there. And often in closets, same thing. You walk in the closet, you back out of the closet, and then you trip and fall again. It's always better to hold onto the wall, hold onto the door jamb, get yourself turned around, and then come up. When you're getting into a chair, make sure that you back up till you feel the chair on your legs. Reach back for a handle, get a hold of it, and then lower yourself down to sitting. Stools and ladders are kind of a no. There's just such a high risk of having a fall, and I saw somebody who was shingling a roof, and I just about had a heart failure. But don't do that. And I know everyone's talked about this, but environmental cues, make sure you don't have scattered rugs, you don't have things lying around you can trip over. If you're getting up at night, that you've got night lights, so you're not walking in the dark. And I think that's the end. So just to remember that gait and balance are affected by both motor and attention cognitive strategies. There's risk factors that can be helped, and exercise cueing strategies, being aware of what you're doing, cognitive strategies and balance training are all helpful. Thank you. Questions?
Do we have any questions for Dr. Jenkins?